Hello, everyone. Hope you are staying warm. I know this is not the ideal situation. So here's another screencast. I emailed you on Monday about a screencast I wanted you to listen to prior to class on Wednesday. So make sure you listen to the one for Wednesday's class. That's about 30 minutes long, and it'll help us with the small group work that we're going to do in class on Wednesday. That is, fingers crossed, everything works out weather-wise. For this particular lecture, I'll probably break this up into a couple smaller chunks. You can tune into this anytime you want to. So if you're feeling busy, feeling overwhelmed, check this out during the weekend. That's perfectly fine. So what's the purpose of this particular discussion? Well, we need to understand that there are local and systemic effects. And when I mean systemic, or when I describe systemic, we're talking about relating to the entire body or throughout the body or affecting the entire body. So some diseases, some disorders will have both those local effects and systemic effects. Now, in this particular lecture, I'm going to list some of the systemic effects of some commonly encountered pathologic conditions, and we'll also take a look at the basic presentation of acid-base and fluid and electrolyte imbalances. So you're going to work with individuals across the lifespan, and you can imagine as you work with individuals who are older adults, that sometimes an individual will be a relatively healthy, active older adult, and maybe all you're working with that individual on is their total knee replacement. Other times, the individual may have multiple things going on, which then challenges their ability to function. Last week, we discussed inflammation. Let's take a look again at the systemic effects of acute inflammation. Again, acute inflammation, that's that initial response to tissue injury, particularly if that injury is something that's musculoskeletal, or if it's something related to an infection or some other process that we looked at last week. So it's that initial response of tissue to injury involving vascular and cellular responses. So there are those local signs of acute inflammation. We talked about those again last week. There can be systemic effects also. And these systemic effects are things that the primary care provider may also be interested in. So systemic effects, fever, tachycardia, or a hypermetabolic state. A primary care provider may order tests to evaluate things like serum protein levels or white blood cell counts. And this can give the provider an idea about disease status. There are also systemic effects of chronic inflammation. And with chronic inflammation, this is the type of inflammation that may not be appreciated to the same extent as an acute inflammatory response. Right, when you have a musculoskeletal injury and somebody has a presentation of swelling, you appreciate that. You see that an injury has occurred. Sometimes with a chronic inflammatory state, you don't observe that. And that can be then that kind of ticking time bomb underneath. So with chronic inflammation, that can be the result of persistent injury, repeated episodes of acute inflammation, infection, cell-mediated immune responses. So cell-mediated immune responses, these involve the destruction of infected cells in the body by the cytotoxic T cells, or the destruction of intracellular pathogens by macrophages. And also chronic inflammation can be caused by foreign body reactions. Now, some diseases associated with chronic inflammation include heart disease, diabetes, cancer, arthritis, and certain bowel diseases. What are some systemic effects associated with chronic inflammation? People can have low-grade fever, malaise, weight loss, anemia, fatigue, leukocytosis. This is the state in which white cells, the leukocyte count, is above the normal range in the blood. It is frequently a sign of an inflammatory response, most commonly the result of an infection. And lymphocytosis, this is a higher than normal amount of lymphocytes. So lymphocytes, part of our immune system, they also help to work to fight off infections. Now, Dr. Sellers will be going into much greater detail about our immune system in a later lecture this term. Malignant tumors also produce many local and systemic effects. Malignant tumors, they have a destructive nature to them because they have uncontrolled cell proliferation, and they spread, and through that spreading, they produce a lot of those local and systemic effects. Now, locally, the growth of the neoplasm or tumor that will encroach on healthy tissue. This can lead to necrosis or death, ulceration, compression, obstruction, and hemorrhage. Pain may or may not occur, depends again on how close the tumor or the swelling or hemorrhage is to nerves. The patient becomes immunocompromised, or if the patient becomes immunocompromised, this can lead to death of the body in response to a secondary infection. Now, a person with a malignant neoplasm, they have these local effects, but the systemic symptoms can be the gradual or rapid weight loss, muscular weakness, anorexia, or in other words, a loss of appetite, anemia, and coagulation disorders. Spread of the cancer may lead to bone erosion, liver, GI, pulmonary, or vascular obstruction. Pressure on the brain can also cause symptoms including partial paralysis and eventual coma. And I have a link here to a YouTube video, and if you want to check it out, you can just download the class lecture for this week. I'm not going to pull it up just because it's going to be a little complicated to move around the recording window. But basically what it is an illustration of somebody exhibiting signs of brain cancer prior to a diagnosis. And this happened, I think, around 2018 when then Senator John McCain was in a hearing and he was talking, but what he was talking about was he was mixing up a lot of different things. And so things were coming out kind of in a garbled fashion, and it just did not make sense. And I remember seeing it live thinking to myself, wow, he must be really tired, or, his mind is just all over the place. But it turned out that he was later diagnosed with brain cancer. And so sometimes you can see the impact of the disease prior to somebody having a diagnosis made. Another thing that our patients may experience are adverse drug reactions. So adverse drug reactions are the unwanted and potentially harmful effects produced by medications or prescription drugs. They can be mild or they can be lethal. Exact incidence of ADRs is unknown. The CDC reports inappropriate medications for older adults occur in 1 out of every 12 visits. There are 7,000 ADR deaths each year, and they account for 2 to 3% of all hospitalizations. Here's a list of risk factors for ADR. So I'm not going to read through all of these, but basically, as you read through them, You get the sense that they are older adults, so they may not be metabolizing drugs as well as they did when they were younger. And they are adults on multiple prescriptions. They may be starting a new drug, and there may be non-compliance, so incorrect use or use with other things that can cause problems. Here are some examples of some adverse drug reactions that you might be able to observe in a patient: rashes, fever, jaundice, erythema, discoloration, itching, burning, urticaria, eczema, acne, blisters, and purpura. So some terms here: erythema, that's that superficial reddening of the skin. Urticaria, those are hives. We see that in our integumentary lecture. Purpura, these are blood spots. Purple colored spots, they occur when small blood vessels burst. Now the onset to an ADR may be in minutes or it may take hours to days. Here are some additional ADR signs and symptoms. And so, again, it's not our job to do medication management with a patient. But let's say you're a home health therapist and you go to visit a patient and they are making complaints of some new signs and symptoms. That may warrant you to provide feedback to the primary care provider or whomever the provider is responsible for this individual's care, that they're having these symptoms so that they are aware of them, because sometimes patients may not be good historians themselves. Medical management of an ADR. So the PCP or the provider that's responsible for care will do an examination. They want to monitor blood cell counts, liver enzymes, electrolytes, the blood urea nitrogen levels, and creatinine levels. Some drugs would warrant ECG monitoring to assess for arrhythmias. So, what do we do for this? Well, first part is prevention, education, and hopefully that's occurring as the physician is prescribing medication to that patient, but it's also important for those who are supporting the provider's prescription. So, for example, in a skilled nursing facility, sometimes you have patients who have pretty impacted cognitive abilities. So, it would be then warranted for the nurse manager and the medical assistants to keep an eye out on changes, because as you try to make those medication, as you try to educate the patient right off the bat, they may not comprehend or understand everything, but you try to do your best with that. Physicians will also adjust medication dosing or discontinue the use of a particular drug. And finally, treatments may be indicated to address ADR symptoms. So this slide here is not for memorization purposes at all. These are potential ADRs and what might be experienced at a particular organ in the body. Okay, let's talk about NSAIDs. So as you can kind of see, this chapter is kind of all over the place, but it's good because a lot of these things are things that our patients are going to be experiencing or taking. So NSAIDs, the non-steroidal anti-inflammatory drugs, these help reduce inflammation, provide pain relief, and reduce fever. We see in Table 5.1 there that there are a lot of different non-steroidal anti-inflammatory drugs. There's both the prescription strength and the over-the-counter ones. These are frequently prescribed for postoperative pain, painful musculoskeletal conditions, and treatment of inflammatory rheumatic diseases. Incidence of serious side effects are low, so that's good, but there are a lot of people that take them, so the number of people who may experience some side effect, some form of side effect, may be common. So risk factors associated with one being adversely affected by an NSAID. Increasing age. Again, their body may not be metabolizing the drug as well. Being on a higher dose. Volume depletion, so a loss of bodily fluids and how that might impact electrolyte levels or other things necessary or associated with body fluids. Concurrent use of corticosteroids or anticoagulants. Anticoagulants, these are medications that help prevent blood clots. Corticosteroids also lower inflammation in the body. And previous history of GI bleed or ulcer. I think one of the most common complaints I've seen people express are GI-related issues. So possible systemic effects of non-steroidal anti-inflammatory drugs right off the bat. Their GI, there's that abdominal pain and some other signs and symptoms. People might also experience hypertension or an increase in blood pressure. So non-steroidal anti-inflammatory drugs can have an impact there too. Some of the most serious side effects or some of the most common side effects that we might see with people having a bad reaction to an NSAID, again, GI tract area, the kidneys, and the cardiovascular system. So looking at the mechanisms of action, well, NSAIDs, they inhibit enzymes COX-1 and COX-2. COX-1 and COX-2 enzymes, these are involved in the synthesizing of prostaglandins. If you remember back to last week's lecture, prostaglandins, one of these components of the inflammatory process, and we looked at different treatments and how they might impact prostaglandins, and if they impacted prostaglandins, how they could potentially help pain. Well, COX-1 and COX-2 enzymes involved in synthesizing prostaglandins from arachidonic acid. Arachidonic acid is an essential fatty acid which we consume in our regular diet. It's considered essential because it is a requirement for proper functioning of the human body. So let's take a look here. When COX-1 is inhibited, there's a decrease in prostaglandins, but also this decreases aspects of the protective mucosal barrier of the GI tract. So some COX-1 inhibitors, although they are helpful for the inflammatory side of things, they have an impact upon the stomach and intestinal lining protection and impact blood clotting control. So COX-1s maybe aren't preferred, and so the COX-2 ones maybe are preferred in some cases because they can block inflammation without those negative side effects. Now, with the COX-1 drugs, we're talking about aspirin, ibuprofen, naproxen. Again, most people, that doesn't cause a problem, and if they use them for the appropriate duration and time, if they're not overusing them, they're probably going to not have any significant issues. The COX-2 drugs that became popular, especially in the early 2000s, were things like Vioxx, Celebrex, and Bextra. And when I was a therapist, these were prescribed a lot. Well, some of the COX-2 drugs were found to increase the risk of heart attack and stroke. And so Vioxx and Bextra were removed from the market in 2004. I don't know if Celebrex is used as much. I don't think it's been pulled off the market. I think it's still in use. I don't know if it goes by a different brand name, but the Vioxx and Bextra were removed from the market in 2004 just because of those dangerous side effects. So again, with NSAIDs, and I talked about this last week, our job's not to prescribe, but rather to recognize if adverse events are occurring. And I know that some people will recommend, or at least some therapists, like when you talk about the peace and love aspect, will recommend against the use of NSAID use. And maybe in some cases, that's okay. And in other cases, maybe it needs to be used. The challenge always is, one, can we get people moving and rehabilitating, or is the extent or the severity of their injury interfering with their process to rehabilitate? So that's always the challenge. And so, some people again are or recommend not using it. Some people have no problems prescribing it. And I think most physicians don't have a problem prescribing it for people. And I think only a change will occur if and when we get to the point where we're doing human trials and comparing similar injuries and looking to see that after a course of treatment, if you do a randomized control trial, you have one group, everybody's got the same exact injury. You have one group that does rehab only, you have the other group that does rehab and use of NSAIDs, and then looking down the line, who rehabs faster? Also, is there any negative tissue health implications? These are hard studies to do. So you can see that there is the clinical challenge that is faced. Again, our job is we work with individuals. We don't prescribe the medications. We shouldn't even be in the process or the habit of even recommending. Let's say you're pro NSAID. We shouldn't be in the process of recommending because you don't know the patient to that extent. And there is the potential that somebody could have an adverse reaction. What we do is if somebody has been prescribed a medication, we need to be able to talk to that patient and discuss with them when they should be taking it, making sure that they are taking it in a time period prior to therapy that will provide the greatest bang for the buck. And of course, checking blood pressure is always important to do because NSAIDs can cause a modest increase in BP. Next up, immunosuppressive agents used traditionally and most frequently in organ and bone marrow transplantation. These are toxic drugs, so they are only used for transplantation situations or some other serious debilitating and non-responding conditions. So here are the major immunosuppressive agents, and there are many adverse effects associated with them. There is an increased risk of infection. These include fungal, bacterial, and viral infections. So, implications for us when working with people who are on immunosuppressants. Obviously, we carefully do hand washing. And if one has a known infectious or contagious condition, that PT should not work with that patient. And both the client and PT should wear a mask in the presence of an upper respiratory tract infection. Okay, let's talk about corticosteroids here. Corticosteroids decrease inflammation. They're used for immunosuppression and as a replacement for adrenal insufficiency. Adrenal insufficiency occurs when our adrenal glands don't make enough of the hormone cortisol. Primary kind of disease here is Addison's disease. Fortunately, it's rare. It's when the adrenal glands don't make enough cortisol and aldosterone. Cortisol, primary stress hormone, it increases glucose in the bloodstream. It enhances your brain's use of glucose and increases the availability of substances that repair tissues. Aldosterone affects the body's ability to regulate blood pressure. It sends the signals to organs like the kidneys and the colon that can increase the amount of sodium the body sends into the bloodstream. Now, we as therapists often see people who have this form of therapy for the treatment of things like cancer, transplants, autoimmune disorders, and respiratory diseases. So here are some potential therapeutic uses of glucocorticoids. Please do not memorize this chart. Here are possible adverse effects of prolonged systemic corticosteroids. And again, a lot of this lecture is just recognizing when something isn't right. You're going to have plenty of, if you just listen to this lecture, you might feel overwhelmed about what you're getting into as a therapist. The reality is, it's not your job, you're not the physician, but we play a role in recognizing. And of course, I think it's also important as doctors that we are a doctoring profession, that we understand the things that people are going through in order to better serve them with empathy, serve them with compassion, and to oftentimes, because we walk side by side with them for a long time during rehab, to look things up and understand what their condition is to provide that source of education for them. So here's those possible adverse effects of prolonged systemic corticosteroids. One interesting one here that we've got a picture for on the next slide is the metabolic side effects, in that it stimulates appetite, and that weight gain is a common side effect. And so here's a figure that I was able to find on Google Images showing, I'm not sure which one's the before, which one's the after, but this individual was prescribed corticosteroids and illustrating the change that had occurred in the presence of that drug. So sometimes pain and discomfort can be masked by this drug, so we must exercise caution when evaluating and treating a patient. There is an increased risk for infection, and hand washing obviously is key. Just make that be something to check off in your brain. As I work with somebody new, I wash my hands. If back pain is experienced by somebody who is on this drug, then diagnostic measures should be performed to rule out osteoporosis or a compression fracture of the spine. Not by us, but by the doctor or the provider who's working with that individual. Okay, we're about 27 minutes in. Let's go ahead, pause this one, take a break, and we'll pick it up with screencast number 2.